Health outcomes. Changes due to interventions. To bring positive change, patient experiences and health must both improve. Healthcare costs must be lowered, and clinician and staff burnout has to end. But our problems are big. 133 million Americans have at least one chronic disease. 500,000 people are dying every year from hospital errors, injuries, and infection. The shortage of primary care professionals will be as much as 100,000 in just the next 5 years. Big problems require bigger solutions. Positive change needs acceleration. It needs to happen now. But these are not so easy solutions that many don't want to hear, and even few are willing to talk about. How to lead such a change? How to discover, discuss, and disrupt healthcare to make a difference now? This is VITALS, Visionary Health Leadership in Action.
Welcome to VITALS. I'm Dr. John Langell, president of Northeast Ohio Medical University. We're pleased to bring you VITALS in collaboration with University Hospitals of Cleveland. VITALS is an open forum to hear from today's national leaders who are transforming the healthcare landscape using the VITALS tools: value, innovation, technology, advocacy, leadership, and service. Today, we are honored to welcome Dr. Jessica Zitter and Chaplain Betty Clark to VITALS. Their journey as colleagues and friends is highlighted in the documentary film, The Chaplain and the Doctor. Dr. Zitter is a nationally recognized physician, author, filmmaker, and advocate working to improve the way we care for patients facing serious and end-of-life illnesses. With more than 25 years of experience as an ICU physician, she has become a leading voice for bringing greater honesty, compassion, and humanity to healthcare. Dr. Zitter is the founder of Real Medicine Media, an organization that uses storytelling and documentary film to inspire deeper connection and purpose in healthcare. Chaplain Betty Clark brings decades of experience in hospice and palliative care chaplaincy. She has dedicated her career to supporting patients and families through serious illness, grief, and spiritual care, serving in both hospice and hospital settings. Let's learn more now about their work and vision for improving healthcare. Please welcome Dr. Zitter and Chaplain Clark.
My name is Tanya Strong Charles, and I'm the Chief Marketing Officer at Northeast Ohio Medical University. And I am honored today to have with us our two guests, Dr. Jessica Zitter and Chaplain Betty Clark. They are based in California, but they're taking their time to be with us today for a very important topic, and that is a documentary film of which they are the title characters, The Chaplain and the Doctor. Welcome.
Thank you.
Thank you.
I want to talk about how the two of you came to collaborate, but first of all, I want to learn a little bit about each of you. So, Dr. Zitter, you have a history here regarding Northeast Ohio. You can talk about that as well, and just your background and why film and medicine are really your passion.
Well, thank you. I am a very proud graduate of Case Western Reserve Medical School. That was a long time ago, and I have not yet been back to Cleveland since I graduated. So I'm really looking forward to coming there on our theatrical tour, which we're in the middle of right now. I'm in Chicago, and so is Betty. And how film, I went to medical school to be a doctor. I had no intention of being a filmmaker. I never even dreamed of it. And what happened was I became a storyteller, and I did a lot of writing of essays and op-eds to sort of explain what was going on in healthcare. What was my experience with the process of being an ICU doctor and a palliative care doctor, and what were all the things that came up for me? And I really wanted to share that in story form. So I was really writing, and I wrote a book. And then eventually I, by total chance, fell into the film world by seeing a film that was filmed at our hospital and seeing the power of it. And that's when I realized I wanted to start directing films myself.
Wonderful. And Chaplain Betty Clark, your path to working in a hospital and treating the body and the mind through spiritual counseling. Could you talk about that a little bit and your background?
Yes. Similar to Dr. Zitter, I had no idea I was ever going to be a chaplain or a minister or a pastor. Grew up in Kentucky sharecropping, got married at 17 and started a family, had a lot of deaths in my family. So I came to California when I was 24 as a widow. My background was finance. I worked in department stores and all kinds of jobs and ended up in finance and moved back to Ohio, where I have family in Cincinnati. And I worked at the Cincinnati Art Museum, Art Academy in finance, and came back to California, still working in finance. But I ended up going into the ministry and was a minister in training and got introduced to hospice when my mother was dying, and decided that's where my ministry is. That's where I want to be. So I worked as a hospice chaplain for 16 years before I entered the hospital as a palliative care chaplain. And that's been 15 years ago as well. So 31 years as a chaplain.
Wow. So the chaplain and the doctor, in each of your roles, right, the work can be soul crushing. Bringing together your talents to ultimately improve patients' lives in some of the most difficult moments they're ever going to face in life. Can you talk about that process?
I think for me, the soul crushingness comes from the moral distress and the moral injury of witnessing, not only witnessing serious illness and death, but being ill-equipped, at least in the early stages of my career. I don't feel that way now, but being ill-equipped to really support patients around difficult decisions, difficult decision-making, acceptance of impending death, all dealing with existential dread. I'll let Betty speak to what her challenges are in the hospital environment, but I think they're very different from my challenges.
Yeah, my challenges come from the people I work with, not from the patients, because I see myself as a wounded healer. So I have experienced a lot of what they have experienced, and I can listen in a way that I'm present and they feel it and they see it. But my challenges come from working with people who see people as different rather than seeing us all as having common bond. And so then I say, a lot of people get, especially working in the kind of hospital we work in, they get jaded. And that to me means that they just sort of get callous to the suffering and the pain of others. And then they become judgmental. And so then they judge people. If you're Black, you're Baptist and you're probably rowdy and you're probably this. And if you're white, you're probably a good family. You come from a good family. And if you're Hispanic, you should learn the language and just all those kind of judgmental things, And if you're angry, it's your problem, not mine. And so that's difficult to help the people I work with understand that people are suffering, and it doesn't have to be because they brought it on themselves. I was at a nurse training, and myself and the hospital chaplain was there with the nurses, and I was part of the training. And a nurse director stood up and said, well, most of the people we get here have brought their illnesses on themselves. And so the other chaplain stood up and said, well, I was from New Orleans and I had surgery there. And when I got to Oakland and I became ill, I went to the hospital and the doctor said they butchered me. And he said, I didn't bring that on myself. And then I said, I was a sharecropper, poisoned with arsenic from the well water, and I have all kinds of illnesses because of that. and I didn't bring that on myself. So you can't look at a person and say, well, they're sick because of their lifestyle, because of the food they eat, or because they've brought it on themselves. And so people become jaded in that, judging people. This one is this and this one's that. And I think my big part with the staff is to bring the story so that they understand what happened to this person, and then to offer compassion to the staff because they need hugs and they need to feel cared for. And they often feel beat up because they hold the other person's anger as if it is part of their own. And I say, that's not yours. That belongs to them. You're supposed to hold your own kindness and gentleness and love. And so trying to help everyone become more human is part of my job.
That's a beautiful message for all of us. And I'm so glad you shared it. I have so many questions. I do think that for our audience, we need to talk about where you work, right? Because some of the things that Chaplain Clark brought up actually are reflective of hospitals across the country, right? Certainly in the Ohio region and beyond, not just California. So I want each of you to sort of, from your own lens, talk about how you view the setting where you work and then that intersection of spirituality and medicine that is explored in the film.
One of the things I think is really important for us to acknowledge in hospitals around the country, and I don't care which hospital, it's very rare that hospitals are non-hierarchical. Even on palliative care teams, I think that hierarchy is something like it is in the rest of society, but particularly in a hospital, that is enforced. We are taught, the doctors are taught to kind of, it's subtle, it's part of this hidden curriculum, but that we're the most important people on the team. And I think Betty would say that chaplains accept the fact that they're at a lower rung, which I think is something we're trying with this film to clarify, that it is actually that spiritual healing is just as, if not often more important than medical healing. And a lot of the time, Betty is the much more important healer in the room than I am. So I just think that we need to look at this hierarchical approach that we have towards the various professions and really start to wonder if we need to turn that on its head. That would be the first thing I would say. And then, your question about sort of the intersection, I guess, of faith and the body. I've just said, I think that there are so many times that I see, you see it in the film, where I have reached the limit of what I can offer, certainly from a medical perspective. I can offer more as a human, but there's something that Betty can do to come in and really bring the healing into a different perspective that ends up being much more helpful and much more urgently needed.
I'm intrigued by your friendship in terms of outside of work. The two of you really started to explore each other's cultures. And also, Chaplain Clark emphasized, or at least hinted at, your own health challenges and how that makes you more compassionate to the patients at your hospital. Can you talk more about what you've learned about each other from a personal level? Because there's some good stories here that are also touched on in the film. Chaplain Clark?
Yeah, well, you will see in the film that I attend a Sabbath, and it's not just for filming. I've attended Jessica's family Sabbath for many years. I learned a lot. I learned a lot from their Sabbath. I learned that children are prayed for and appreciated in a way that I just feel like all families should do something like that and bring the family together every week and sit down at a meal and just bless the children and let the children know they're blessed. That really impacts me. Jessica has been to my house and she's met my great-grandchildren, grandchildren, and so forth. And there's love, there's family love, because I keep emphasizing because we're human, because we're one big earthly family. And it would be wonderful if everyone felt that way. But health-wise, Jessica has supported me because the whole hospital does. But of course, Jessica does personally. But I have this unusual body that has been through a lot and is still ticking. And someone was walking with me in the hall and they said, God's holding you together by different means. And some of the doctors will say, I never met anyone that didn't have a colon. And I had one doctor who did lots of surgeries on me. He said, Betty, I'd like to still have you as a patient, but you don't have anything left to take out. And so stress, work, worry, all of that stuff brings us down physically. But I think that it is the spirit and the spiritual part that lifts me up and keeps me going. I don't think I'd be here. I don't think I'd be here on this earth if it wasn't for the spirit. If you don't have the spirit to lift the body when the body is going down, it's nothing to catch you. You keep going down. You stop eating, you stop taking your medicine, you stop doing the things that keep you going because your spirit is so low. And so I feel like I'm a doctor of the spirit. I'm a caregiver of the spirit. I'm a midwife of the spirit. I just believe that the spirit is that important in a person. And whatever lifts them up, whatever it is, whether it be their beliefs, their religion, a walk on the beach, their pet, a Harley, whatever lifts them up, that's what I want to help them with so that they can continue to be lifted up.
Jessica, people look at you as, a brilliant physician, an ICU physician. You have people's lives in your hands. And at the same time, again, this relationship with Betty, what have you learned from this that helps you in both your personal and professional life?
I'd say the thing that I have most learned from Betty, which has been one of the most valuable lessons that I could have learned as a doctor and didn't learn, honestly, in medical school, is that everybody has a story. And that if you take the time, it doesn't have to be a lot of time, it could be very quick to connect with someone's true, authentic story. Not only will you be less likely to allow normal pieces of implicit bias, that's part of the human brain, but you'll be less likely to have it creep in to your care of that person. You will be more likely to be the healer that we all want to be. You will be less likely to have the burnout and moral injury that I lived with for so long. There's so many things I've learned from Betty, but that is probably the biggest one. Take the time as much as you can. Of course, sometimes things are crazy, busy, but just try to take the time to get somebody's story.
Do you have any advice for the medical students who are watching this, or perhaps the resident who is feeling overwhelmed, thinking, how do I do that? And many doctors, right, feel that they are on a time limit. They feel that they're going to get deemed for inefficiency, right, if they don't keep moving to the next patient.
I've had several encounters with young medical students, senior medical students, and one of the things that I found out is that they don't get in touch with real life. They're sort of protected and isolated from grief and suffering and pain. And so I tell them it doesn't have to be their own, but just get involved, get connected with someone suffering. They may have a friend who relationship broke up, or they may have a friend who lost a parent, but get in touch with what grief and loss is about, because that's a lot of what they're going to deal with.
Yes, I think that's true. And I do think there's truth to the fact that medical residents, medical doctors often don't have time to sit and get the kind of story that Betty can get or that I can get when I'm on the palliative care service. Sometimes it's just too little time. But there are still ways, without getting the entire story, that you can connect with a patient. There's smaller ways, connecting around some emotion, acknowledging the emotion. That doesn't require getting the person's entire story. It just requires getting the story for that moment. You're angry. I'm so sorry. I want you to know that I'm going to try and do my best to address the things. I'm so sorry I have to run right now, but I want you to know that I'm thinking about you and I really care. Even if they get angry at you after that and still say, but you're not, doesn't matter. Bring your humanity into that room for a short period of time or as long as you can, and it will fundamentally alter the state of the next several days and how they feel about you and the healthcare team.
I had a call from a doctor who wanted me to see this patient because she was an identical twin and her twin sister had died. So I went in to see the patient and she started crying as soon as she saw me. And I asked, well, why are you crying? And she said, you look like my mother. Her mother also had passed. Listening to Jessica, the doctor didn't do anything except call me. He could have had a wonderful moment with that patient just by letting that patient know, I understand that you have a lot of grief. I want you to know I'm thinking about you, as Jessica said. Just a few words, but quickly they will run and call a chaplain. And, oh, this person needs a prayer. This person needs this. Or else sometimes they'll say, well, I wouldn't go into that room because they're very angry. And I said, no, I'm going in.
Yeah.
And then I'll come back out and I'll tell them, do you know this story? And this is what's going on.
I want to remind our audience that the patient's voices are central to the film, The Chaplain and the Doctor. And Jessica, I'd like to know what most surprised you about these patients' voices.
What most surprised me about that was not them, but it was me. What surprised me was the fact that I didn't understand for so many years of my career that there was a voice to be heard. Oh, that's the patient in bed 5 who believes in miracles, or that's the patient in bed 3 who is drug seeking. And there was no, maybe I'm a worse kind of doctor than a lot of the young people on this, but I think it's a real problem in our profession. We believe that we're supposed to know the answer about everything, about prognosis, about diagnosis, about what to do next, and about what kind of person that is. And I think that's what I was most surprised by, is how much I did that and how much when I didn't do that, things shifted into a very different experience.
I was going in with a doctor, one of our doctors, and we're standing outside the room, and he was trying to tell myself and the rest of the team what to expect when we go in. And he said, well, this person is drug addicted. And I looked at my paper and I said, well, it says here they have cancer. I mean, if a person has been on drugs 30 years before, and now they haven't been on drugs for 30 years, but it's in their chart. Many times the doctors will go straight to the drugs addiction and not to the diagnosis.
This is reflective of the implicit bias that Jessica was talking about. But at the same time, I do want to get to what needs to change. We want to be positive, right? We have a lot of young people who are signing up to be medical doctors, to be physicians. Yay, right? And we want them to be in all types of specialties and primary care because we need them and we don't have enough doctors. And we need them to understand the value of working with people like you, Betty, right, to improve the profession. But I do want to ask Jessica about this in terms of the training. You said, oh, well, maybe to some young people, I'm the worst doctor ever. But aren't many doctors or most doctors trained that way, to look at people as a statistic? You know, a 40-year-old white male who's a smoker, a 50-year-old Black female who has diabetes or is pre-diabetic, and what that means in terms of treatment. But the scary part when you're that person, right, is that you're being dismissed. That's what Betty has been talking about also from a cultural standpoint, which she explained at the beginning of our conversation. But Jessica, what do you have to say about that?
Well, what I would say is that we have data after data after data of bias towards people for a whole variety of things. Because they're smokers, because they have a tattoo, because they're a woman, because there's so many. And so the way we're taught to present a patient, in rounds is really objectifying. All of those words you just said, they're very objectifying. And we're not encouraged to give any piece of real social history. Maybe, oh yeah, they live at home with their mother, but there's not a push to bring some piece of their humanity into rounds. And I think that would make a huge difference. And I think that's one of the roles that a chaplain plays, is to help bring that humanity into the thinking of that patient. So we're taught to objectify patients and nothing else. I mean, again, I'm being stark, but I just want to say one more thing to the young doctors and doctors in training on this podcast. There is no greater privilege and no more wondrous thing in my life than being a physician. And what I just would change and wish I could go back and change is exactly what I said, which is try to find those points of contact with your patient, because this whole thing you're hearing about physician burnout, it is mitigated by having a humane connection with your patient. So don't feel overwhelmed. Don't feel distressed. There are ways to improve that piece of the experience of burnout and of feeling that disillusionment. And that includes really figuring out ways to connect with people in a way that we aren't really actively taught in medical school.
Betty, you have something to add to that?
Yeah, I wanted to say that as I've worked in the hospital, our hospital, which is a hospital filled with people who are underserved and under-resourced, and it can bring the workers down. But people's attitudes have and spirits have gone up. Doctors are coming to me for hugs, and because if a chaplain sees a doctor in the hall and they look like their spirit is down, they should offer them a hug. It makes a big difference. And now I don't have to even offer. If they come out of the room, they say, "Oh, I had a horrible time. Betty, I need a hug." And they get hugs and they're lifted. So we're there to not just lift the patients, but also to lift the doctors and the nurses, because the work is really hard. But it is rewarding when they can feel that they're appreciated. Everyone wants to be appreciated. And I just finished doing blessing of the hands. And in our hospital, I had charge nurses and nurse supervisors and administrators, and all coming around to get their hands blessed, because the work is rewarding.
Listening to the two of you, people are going to want to find out more about this film. Let's make sure we clarify this, a missed point that hasn't been stated yet, I think. Let's say the hospital where you work, if that's all right.
Sure.
Okay. And how long you each have been there. So, Jessica?
I think I got there a year before Betty. It's Highland Hospital of the Almeda Health System. It's the safety net hospital in Oakland, California. I've been there since 2009, and Betty got there in
2011.
Okay.
We've been working together since then.
That's amazing. And let's talk about how you came together on this film. We know that, Jessica, this is your third film, right? Your third documentary. So tell me a little bit about bringing this one to light.
Betty, as I said, she grabbed my attention about a few years into our work together and really helped me to kind of reframe a lot of things, to look inward, to question the way I was approaching my patients, myself. And I started to become very inspired. And I really, was every day I would come to work and Betty would say something that caught my attention. And I'm a writer, so I was writing a lot. I was writing a lot of op-eds. I wrote a book, and I wanted to record Betty with my phone because I just found her to be saying things that I thought were really important and that I was cogitating on. And so one day I saw a film that was filmed at our hospital called The Waiting Room. And I realized when I watched it, how incredibly powerful it was to actually watch a story on a screen. Reading it is powerful too, in a different way, but frankly, most people aren't reading anymore. And just being able to witness this thing on the screen, it's kind of like people watching The Pit. It's like real. It's something we've all gone through. All the different things that are happening on the screen are things we can relate to. And I think it made me realize this is a modality, this is a medium that I must use to get some of these stories across.
Wonderful. Betty, you have talked about a little bit, as I said, your own health challenges. Has Jessica had an impact on you in that regard as well?
Yes. Of course, she always encourages me to get treatments or to get procedures. things that I don't want to do, but just to have a friend who cares as much as Jessica cares, that I can call any hour in the middle of the night, that my daughter can call and ask to help her with a question, even if with the grandchildren, is so valuable. The doctors at the hospital look after me. Even on our team, they'll say, "Okay, Betty, have you had water today? Have you been drinking any water today?" And well, come on, we're going to go get some water. And just to have that is so valuable and so wonderful to have that respect and just love. And Jessica is always beating herself up, and she'd come to work and say, "Oh, I'm sorry, I'm late." And I say, sorry, love means never having to say you're sorry. So I changed the time on when we have to be there. If it's 5 minutes after you're on time, you're not late. So
I like that. I'm going to hold on to that one. And I can tell by just the intensity with which you love and care for these patients, and that you are serving as a voice for the voiceless. It probably could be challenging in some cases to accept that, right? And it sounds like you both are able to receive love while also giving this extended care, right? You're going above and beyond both of your professional descriptions to make a difference in people's lives. Does that become hard, sharing such intimate moments which are on display in the film?
It working hard together and being stressed together, I think, brings us closer, and we help each other. I can see Justin, but you need a break. You're getting, and she can say the same thing to me. So working together, doctors and chaplains working together, really help each other. It's a prescription for what's going on with the patients who are struggling spiritually and physically. And so when you've got a spiritual person and a physical person working together, Jessica can identify my physical weaknesses and my physical needs. I can identify her spiritual ones. And then we will help each other. And I think that's what we're talking about in medicine.
Wow, that's inspirational. Jessica?
I think actually, Betty, I've never heard you put it that way before, but I think that's really true. And I think that's what happens with us. And I think it can happen for many more people, to find a partner, find many partners, normalize sharing the distress, sharing the burdens, and coming together to provide that kind of support. I don't think enough of that really happens. Residents on the wards, or you have a friend here or there, but to have it become a normal part of the culture where people really are sharing more about what they're going through and seeking support from each other, I think would really turn things in a much better direction.
So is that how you see, sort of as a prescription for improving even medical education moving forward? Do you have any comments on that?
Well, I'll say our nonprofit, Real Medicine Media, that's REEL, Real Medicine Media, and you can find it online at realmedicinemedia.org, is all about using storytelling to try to bring a shift to the way we think about healthcare culture, medical culture. And by just showing people, it doesn't have to be, it's not didactic, it's not finger wagging, it's not PowerPoints, it's a story. And it's showing the challenges in that story and possibly a new way forward. But what it does is it provokes new thinking, new inspiration, an emotional connection, and hopefully that will help to shift where we're going. Obviously, we want to provide that film and other kind of curricula that we create with some kind of didactic experience, something to walk away with, but really to have the film be generative of some kind of inspiration for change.
And I want chaplains to see the film and to see that their role is broader than, they're not pastors in the hospital. They're not Bible thumpers in the hospital. They are spiritual people who can lift the spirits of not only the patient, but the doctors as well, and change the culture in the hospital. We have several doctors who were seen as being just unreachable and mean, but just speaking to them and smiling at them and giving them a hug and asking how they are today, they've changed. And so I think that that is some part of the chaplain's job and responsibility in a hospital setting.
I just love hearing from both of you emphasizing that there is power in caring. You are talking about the care in healthcare, right?
Yeah.
That's
Yes.
what this has been all about when we talk about the chaplain and the doctor. Tell us how people can see this, Jessica, across the country and for, a long time. You don't have to be in the city at a certain time to see it. It may come to your city.
Well, let me give you a quick rundown. What I would love for everybody on this video cast to do is to sign up for the newsletter, because we're going to have ongoing information about how to see the film. And if you want to sign up for the newsletter, what you do is you just text the word caring to 66866, and then you will be part of our community. The way we're doing it is we are bringing the film around on this national tour, which is going to go probably through early fall. At the same time, we're doing community screenings. Some places are asking us to come, please share the film, and sort of more private, hospitals, et cetera. We're doing that. And by the way, not just in person, but virtual community screenings. And then we're also going to start streaming. So we've got lots and lots of ways for people to see the film eventually. We're not yet ready to put it out there. We're really still trying to kind of have this educational, impactful screening series, which we're doing now, and then eventually the community screenings and virtual screenings. But then eventually it's going to be streaming for anybody to use.
And like you said, it's for anybody, right? It's not just for physicians or chaplains. It's for patients. It's for anybody who has a loved one, anybody who cares about the healthcare system, anybody who cares about workforce development and how we train our doctors and nurses and healthcare workers.
Well, the San Francisco Chronicle said it's a must-see for anybody who cares about healthcare. So you were quoting the San Francisco Chronicle.
Okay. Well, I hope that they don't accuse me of plagiarism, because I mean it when I say it. I thought it was in my own words. All righty. Final thoughts from both of you. I'll begin with you, Betty.
Well, I was going to say that one young man came up to me and said, my uncle passed, and I wish someone like you had been at the bedside to hold my hand and hold his hand. And I think that says it all for me, that we need to be there for people, all people.
Yeah.
Thank you.
And to add to that, we need more chaplains. We need to not be cutting chaplains first thing when our Medicaid budget gets slashed. Chaplains are also not only an incredibly important part of the humanity in healthcare, but they're also cost saving. So that's a very important thing to understand, like palliative care. But my final thought would be, let's reassess how we're teaching people. Let's reassess how we are acting towards each other as healthcare providers. And let's start to realize that we're missing some things that are causing us to all get buried by a lot of moral distress that we could be avoiding if we had a more humane, humanistic approach and a more team-based approach.
You've shared a lot of hope today. You've inspired a lot of people. I'm absolutely certain of that, and inspired change, right? We need our healthcare system to operate well, but we need the people within it to communicate and to care about each other. I can't thank you enough. I'm honored to have had the opportunity to interview you both today for VITALS. And now we're going to throw it back to Dr. Langell to wrap up this episode.
Thank you for joining us for VITALS. We look forward to seeing you for next month's presentation. Visit neomed.edu for more information.
Health outcomes. Changes due to interventions. To bring positive change, patient experiences and health must both improve. Healthcare costs must be lowered, and clinician and staff burnout has to end. But our problems are big. 133 million Americans have at least one chronic disease. 500,000 people are dying every year from hospital errors, injuries, and infection. The shortage of primary care professionals will be as much as 100,000 in just the next 5 years. Big problems require bigger solutions. Positive change needs acceleration. It needs to happen now. But these are not so easy solutions that many don't want to hear, and even fewer are willing to talk about. How to lead such a change? How to discover, discuss, and disrupt healthcare to make a difference now? This is VITALS, Visionary Health Leadership in Action.